That renal cell carcinoma is the third most common cancer in GU cancers, actually, after bladder and prostate in Saudi, and it constitutes for 3% of male cancers and almost 2% in the female cancers. In 2006, this is the landscape, metastatic renal cell, only interferon, and this year we have all of these medications to choose from, and it's really amazing that our patients, they have all of these options at this point. So this is the current NCCN guidelines. We have in the first line pazopanib, sunitinib as preferred options, as well as the historical bevacizumab, interferon, and other medications. In the subsequent therapy lines, we have cabozantinib, nivolumab, axitinib, and lenvatinib, everolimus, and pazopanib or sorafenib if they are not treated before with that. So this is the current kidney cancer drug therapy and this year, and we'll go inshallah in details. First, the revolution started with sunitinib. That was in 2007 with this trial, which showed that sunitinib increased progression-free survival versus interferon, which was the standard of care at that time in the first-line data. Sunitinib improved progression-free survival to 11 months compared to 5 months in the interferon. And then pazopanib joined the game and was compared at this time to placebo, and pazopanib improved PFS to 9 to 11 months compared to 3 to 4 months in the placebo. And then we had these two effective drugs. So this COMPARES trial was comparing pazopanib to sunitinib, non-inferiority study. And pazopanib was non-inferior to sunitinib, although there was some numerical differences, but at the end of the day, it was non-inferior. Trying to see the differences, this study looked at the patient preferences between the two medications, starting with either pazopanib or sunitinib for 10 weeks, 2-week washout period, and then the other medication for another 10 weeks. Then it's the patient choice to continue till progression. And as expected, 70% of patients preferred pazopanib compared to 22% of sunitinib. There was a quality of life study along with the study, despite some concern about the timing of the surveying patients about quality of life. So what about second line? So started with ACCESS study, which looked at axitinib compared to sorafenib, which was the standard of care, in second line therapy for metastatic renal cell carcinoma. So axitinib prolonged progression-free survival to 6.7 months compared to 4.7 months for the sorafenib, which was significant. And axitinib was approved for second-line treatment for metastatic renal cell carcinoma. And then more recently, we had the METEOR study, phase 3 study, comparing cabozantinib versus everolimus in the second-line setting. And cabozantinib induced more responses. So we see the partial responses 17% compared to 3% for everolimus. Also, PFS was improved in cabozantinib group to 7.4 months, and also overall survival 21 months to the historical expected 16 months of everolimus. The curves are nicely separated. The clinical benefit was consistent in both bone metastasis and visceral metastasis patients. Quality of life was maintained or similar in both arms, and that led to approval of cabozantinib in the second line. Then lenvatinib, preclinical and phase 1 studies suggested some synergy of lenvatinib with the mTOR inhibition, and that led to this study which compared lenvatinib plus minus everolimus compared to everolimus alone in the second line metastatic setting. This was presented in the, I guess, ASCO 2016. So now we see complete responses with this combination, 2% in the lenvatinib everolimus combination, partial responses 41% compared to 6% of everolimus. Also, PFS was prolonged, 14.6 months in the combination compared to 5 months in the everolimus. Overall survival was 25, again compared to the 15 months in everolimus. This clinical benefit was at a cost of toxicity, and we can see it that 71% of patients required dose reduction in lenvatinib everolimus combination, and that 25% of them had to discontinue treatment because of toxicity. And that's why this combination did not really make its way to our real clinical practice in the clinic. And then immunotherapy joined, and this phase 3 trial compared nivolumab versus everolimus in the second-line setting. And response was improved in the immunotherapy nivolumab arm, 20% compared to 3% in everolimus. PFS was the same, but survival was improved to, which was the primary endpoint, 25 months compared to 19 months in everolimus. Also, that clinical benefit was consistent and seen clearly in patients with bone metastasis as well. UTNet improved clinical activity with even better tolerability in the nivolumab arm. Quality of life was also improved in favor of nivolumab. And that led to the approval of nivolumab in the second-line setting. And then we had cabozantinib worked well in the second line, so they wanted to bring it in the first line, and we had this phase 2 study, which was published in July 2016. Phase 2 trial, though, cabozantinib versus sunitinib in the first line setting. Cabozantinib improved progression-free survival to 8 months compared to 5.6 months. Response rate was better. Survival was 30 months compared to 21 months for sunitinib. This, of course, should be taken in the context of phase 2 trial, awaiting the ongoing phase 3 trial to confirm it. Not to mention the financial toxicity of cabozantinib. And then most recently, this study was presented in the last ESMO last month, which is, looked at the combination immunotherapy nivolumab with ipilimumab in the first-line setting versus sunitinib. So this is the design of this study, treatment naive, first line. They were randomized to 2 arms, 3 milligram nivolumab, only 1 milligram, this is kind of the lower dose of ipilimumab, which was wise, 4 doses, and then to continue nivolumab every 2 weeks, versus the traditional dose of sunitinib. The patients were stratified according to their prognostic risk group. So the primary endpoint was response rate, PFS, and overall survival in the intermediate and poor risk group. The secondary endpoint was the intention, the whole population, which included also a favorable risk group. And this is the population patient characteristics of this study. We can see 2 cohorts, the intermediate poor risk, and this the whole cohort, which they call it intention to treat. We see there's 0 favorable risk group in this group. This is important when we look at the outcomes and results of this study. So the primary endpoint was PFS in the intermediate poor risk group, which was prolonged in the combination immunotherapy nivo-epi to 11.6 months compared to 8.4 months in sunitinib, which was statistically significant. Overall survival was also prolonged, not reached in the immunotherapy combination, 26 months in sunitinib, with amazing hazard ratio of 63, so 37% reduced risk of death. And the intention to treat also, overall survival was not reached compared to 32 months in the sunitinib, which was statistically significant. However, PFS was the same in this group for the two arms. When we look at the favorable risk group, sunitinib did better with a PFS of 25 months compared to 15 months in the immunotherapy combination group. So it's really interesting to see a drug or a regimen to defeat sunitinib in the first line. This took 10 years and the combination chemotherapy to immunotherapy to do that. They looked at and they pre-specified the PD-L1 expression, and they found that the clinical benefit was even better in those with PD-L1 positive patients. We can see here in the intermediate poor risk group, 58% compared to 37%, and the intention to treat 53% compared to 36%. Also, the complete responses, 16 versus 7, and 14 versus 9. So these are the curves according to the PD-L1 expression in the study. PFS was the same, but when we look the same in the PD-L1 negative, but in the PD-L1 expression more than 1%, it was clearly improved in the immunotherapy combination. 22 months versus 6 months. And even the combination immunotherapy was more tolerable than sunitinib, with the expected autoimmune side effects. These are the all grades, but the grade 3-4 was 5 in the diarrhea, 6 for hepatitis, some for thyroid dysfunction. So that's what we expect and what we learned from previous trial in immunotherapy. Also, quality of life was improved in the immunotherapy combination. So summary of this trial, the combination immunotherapy improved clinical outcomes, specifically overall survival, with 37% reduction in the risk of death. In patients with PD-L1 more than 1%, the clinical benefit was even better. And those patients with favorable risk group, they achieved higher response rates and PFS with sunitinib. So sunitinib might maintain itself in the first-line setting for this favorable group. We're expecting, I was talking to friends this morning, we're expecting approval of this immunotherapy combination in early 2018. So a lot of advances, a lot of evidence came, changed the landscape of renal cell, but the story won't stop at this point, awaiting many ongoing combination trials in the first-line setting. We talked about this trial, atezolizumab, bevacizumab, they are all compared to sunitinib, velumab, axitinib, also Bempro with axitinib, lenvatinib, everolimus in the phase 3 trial compared to sunitinib this time. And my conclusion is that emerging data are awaiting and anticipated in the targeted therapies and combination therapy, and they include TKI monotherapy, cabozantinib, combination PD-1 and anti-CTLA-4 ipilimumab therapies, or combination. I find this more interesting, and I'm really waiting for the results of this study when they combine immunotherapy with anti-angiogenic therapies. In the second-line setting, the current treatment landscape includes anti-angiogenic agents, mTOR inhibitors, and immunotherapy nivolumab. And thank you very much.